If you want to interpret ECGs effectively, you must first understand the electrical flow in the heart, which is why we talk about electrophysiology. A couple of terms you need to remember. First is resting membrane potential. This describes the state of a cardiac cell at rest. The inside is negatively charged and the outside is positive. The next term is action potential. This term can be confusing because of the word potential. We're actually talking here about that potential being activated or acted upon. This represents a change in polarity, a shift of the electrical charge. This is how cardiac impulses originate and also how they pass from cell to produce conduction and to produce contractions. In the resting state, there are large quantities of sodium outside of the cell and potassium on the inside. At rest, the electrical charge, or the membrane potential, is approximately a negative 70 millivolts. I don't care if you remember that number, but it's important to remember that the cell has a significantly negative charge at rest. At some point, the membranes become widely permeable to sodium. In most cardiac cells, that happens when an outside stimulus triggers a response. In the case of pacemaker cells, that shift happens spontaneously, which is the automaticity property of cardiac cells that we talked about previously. When the membrane becomes permeable to sodium, sodium rushes into the cell, rapidly changing the electrical charge from significantly negative to slightly positive. This is the action potential. We know that sodium and potassium move in opposite directions, generally speaking. Some of this happens through passive diffusion, and some is facilitated by the sodium-potassium pump that actively works to move the cell back to its resting potential. This process is repolarization. This image shows the differences in action potentials in three types of cells: skeletal muscle, cardiac muscle, and pacemaker cells. Remember that the muscle cells comprise about 99% of the heart. You can see that skeletal muscle cells don't depolarize quite as fast as cardiac cells, but they repolarize very rapidly. You can also see two important differences in cardiac muscle cells compared to pacemaker cells. The first is that there is no change in the electrical charge at rest until a stimulus comes along to initiate depolarization. In the pacemaker cells, there's no actual state of rest, as the cells actually transition on their own towards a threshold where that depolarization will occur. The other difference in pacemaker cells is the absence of a plateau in the second phase, which allows those cells to repolarize a little faster than the muscle cells. In the next few images, the action potential is shown in approximate relationship to what is seen on our ECG tracing. There are 5 phases of the action potential we will discuss. They start with phase 0. Don't ask me why they aren't numbered 1 to 5, because I have no idea, other than this is medicine and it's supposed to be hard to remember. Phase 0 represents the rapid influx of sodium and the transition of the cell from negative to positive, which again is what we call depolarization. In phase 1, at the end of depolarization, the sodium channels close and potassium channels open up briefly, and the electrical charge of the cell drops to about 0, which helps to trigger the movement of calcium. Phase 2 is the plateau, when the slow calcium channels open up, allowing extracellular calcium to flow into the cell. Calcium is required for contraction to occur, and you will recall that the pacemaker cells don't have myofibrils, so this plateau doesn't exist in those cells. The movement of calcium into the cell also impacts how quickly the cell reaches stage 3 or repolarization, which is how calcium channel blocker medications work to slow heart rates. Phase 3 of the myocardial cell is repolarization and follows the closing of the calcium channels. The cell has a mix of positive and negative charges on both sides of the membrane as the sodium-potassium pump works to move things back towards a resting state. Muscle fibers begin to relax and lengthen. The available levels of potassium have a significant impact on the efficiency of this repolarization process. This graphic shows the relationship between the ECG tracing we see on our monitor and the depolarization and repolarization process we just described in each part of the heart. Keep in mind that this wave of electrical activity flows very quickly through all the cells of the heart, and our ECG machine measures the net effect of all that electrical activity in a single waveform. If you could break it out and measure each component individually, this is what it might look like. The QRS complex represents the largest electrical activity, which is depolarization of the ventricles, and that is the most obvious waveform in most cases. The T wave represents the repolarization of the ventricles. We can think of repolarization as filling the tank. If the heart cells were toilets, repolarization is filling the tank and depolarization is the flush. We also talk about stages of repolarization. Phase 4 is when the tank is full. When you hit the handle, you get the full and appropriate response that that device was designed to produce. When the tank is not full, the cells are in a refractory period, meaning they're not likely to produce the usual full effect. We further divide those into two subcategories: the absolute and relative refractory periods. I know everyone has experienced the need for a second flush. You flushed and are ready to leave and notice that for whatever reason an additional flush is needed. You don't really want to wait for the entire time it takes for the tank to fill, so you hit the handle too early. If you hit that handle right after the flush, this is the absolute refractory period, and it occurs from depolarization through the middle of phase 3. During this time, the cell is incapable of responding to a stimulus because it hasn't had the chance to reset. Pacemaker cells at this stage cannot spontaneously depolarize either. If you wait until the tank fills partially, but you aren't patient enough to wait until it's full, now we're in the relative refractory period. You may get a normal response, or fairly normal. You may get a partial but ineffective flush, the equivalent of cells responding but not necessarily normally, or you may get no response at all. This occurs from the middle of phase 3 to phase 4. And this is also where the issue of an R on T phenomenon comes in. When a new stimulus hits right in the middle of this relative refractory period, our patient is at risk of going into VTAC or VFib or even asystole. This is also why we have to use synchronized cardioversion in order to make sure that we don't deliver a shock right in that vulnerable stage of the cycle. Some clinical considerations about all of this action potential information. Catecholamine administration, or sympathetic stimulation of any kind, raises the slope of phase 4. Depolarization occurs more readily, and heart rates increase as a result. Parasympathetic activity, on the other hand, flattens and lengthens phase 4, decreasing the firing rates of the pacemaker cells, which is why vagal maneuvers will slow someone's rate. As I mentioned earlier, calcium channel blockers prolong phase 2, especially in myocardial cells, those muscle cells, delaying repolarization and also decreasing contractile strength. These are just a couple of examples, and as we learn about ECG interpretation, I strongly suggest that you keep this graphic and this information in mind. Memorizing waveforms and interval measurements is also important and it's helpful, but in order to be proficient at ECG interpretation, you need to be able to visualize what is happening in the heart and what is causing it as a cellular level as you try to interpret what those waveforms are telling you.